Not my expertise. Our EKG is coming up. There we go. So let's just get it first. Okay, same sort of look. So again, enter chest wall, right ventricle, left ventricle, aortic valve, mitral valve. So far everything looks normal. Capillary muscle, chordae. Can you freeze it? Okay, where's our cursor? Okay, good. Why don't you move back? Keep going back. Keep going back. Keep going back. A little more, a little more, a little more, a little more. Okay, see our cursor right here. What period of the cardiac cycle should we be in a general sense?
Contraction.
Systole, diastole?
Systole.
End diastole, okay. So at end diastole, what do you expect the ventricular chamber size to be relative to if we move forward? Should be maximally filled. Okay, let's move to the right. Let's watch our ventricular chamber. And you see it contracting and there. And we actually make that estimate that by its smallest dimension, it's not perfect, but it's pretty good. This is end systole. Okay? And we can get more precise than that. So let's go back real time. Okay? Let's put on some color flow here. And again, we can see flow from the left atria into the left ventricle, and then we don't see it as well because, again, the transducer's here and the flow is out here into the aorta, but we can see flow that begins to go out the aortic valve. Okay. Why don't we just go to a short axis here. And again, here we're seeing the left ventricle with the right ventricle that you can appreciate anatomically is more anterior and almost wraps around the left ventricle. Again, capillary muscles down below. We can see nice contraction and relaxation of that ventricular chamber. If a patient had, for instance, a myocardial infarction and it killed a piece of their heart muscle, if we only took one little slice of the muscle, it might look completely normal. And that's why we need to look in lots of different views to appreciate what's going on. Okay, why don't we go to a four-chamber view? So we're going to go down towards that point of maximal impulse again. It's the apex of the heart. Let's see if we can get a TR here. So as I mentioned, we can use some of the calculations to measure pressures in the heart. Here's our tricuspid valve. Okay, the tricuspid valve is always a little more apical compared to the mitral valve. If someone has a congenital abnormality that they have the right heart on the left side, we denote what chamber it is by where that valve is. Okay, so we're seeing the valves open and close. We're going to see if that our subject, Evan, has any leakage across that tricuspid valve. As we said, there's a high percentage of people that do. No. All right, but he doesn't. No. All right. So in that particular case, we would not be able to use that Bernoulli equation to calculate pressures inside the heart. Many people, we do have some. There may be a tiniest flick of it. Let's see if we can capture some. So beyond the color flow Doppler, there are other modalities, one of which I showed you with that aortic valve, such as continuous wave or pulse wave Doppler. I'm not going to go into the nuances of it. One basically is transmitting and receiving a signal continuously. We generally don't image. Another is sends it out and then waits for the signal to come back, the pulse, and we listen to it, as we're doing here. we see this tiny little signal here. And that likely is the tiniest squirt of tricuspid regurgitation. It's not as clear as that value I showed you for one of our other patients. Why don't we look at inflow? So let's look at mitral inflow. Yeah. So we're positioning, this is the Doppler cursor, right below the mitral valve. Perfect. Okay, just freeze one when you get one back. Perfect. Freeze. Good. So, here's the apex of the heart. You can't see it, but my magic eyes can. The mitral valve right where I'm showing you the green cursor there. The Doppler cursor is picking up flow below it. So the flow of blood is going in diastole from the left atria into and filling the left ventricle. What period of the cardiac cycle is here? Systole or diastole? Look at your EKG. So this is diastole. Okay. What's going to happen just after the mitral valve opens, which is difficult to see right on here? Blood's going to flow in, and we see this wave here, which is in echo parlance termed an E wave, or the early filling. As that valve opens, blood flows in. Then there's a period of diastasis. We have our P wave. What's going on here? Atrial kick and an A wave. So we have flowing of blood because of the pressure differential, where I talked to you yesterday about even a suction gradient into the left ventricle that produces this early filling. We then have a period where there's relaxation as pressures begin to equilibrate. We have electrical activation from the sinus node. The atria get stimulated, contract, and we have subsequent to that P wave an A wave that develops. And so we can get cardiac cycle events from our echo. Okay. All right, we're going to be running out of time, so Evan, why don't we thank you. And I may mispronounce this name, but it's Jeffrey Tweed here. All right, come on down. Any questions on anything so far? Yeah.
I just have, I guess, with all the inefficient too much going into the 2D transmissions.
Yeah.
That's each of those different transducers sending out a different frequency, or they all do the same one?
We can change the frequency of the transducer as we go. The frequency that it's transmitting at, we're not going to get into the details, and I probably couldn't explain it in the depth you want, but depth is the key, is that everyone's has a different chest wall. As an example, we have a special echo machine in my laboratory where we can echo mice. Mice have, anyone know what a typical mouse heart rate is? When they're running around at night, which is a typical time they run around. Someone says 300. Any other guesses? About 800. Okay, so 600 to 800. So the frequency of the transducer has to be able to pick that up. Also, the depth from the chest wall is such that in one of our patients here, our subjects here, is different than a mouse, and this person is different than many of the patients we have in the VA hospital that might have larger chests. So we can change the frequency dynamically on the machine with a dial. But at any one time, I think most of it is being sent out. There's multiple crystal arrays, the phased array crystal that sends out multiple beams at the same time. Okay, so let's see if we can get PR here right off the bat. So again, that apical view, left ventricle, ventricular septum, right ventricle. You can see the different shape of the right ventricle, tricuspid valve, mitral valve. You see our pictures are a little different, and as I mentioned, I think to some of our volunteers yesterday, we can't predict whose pictures are perfect and whose pictures are not, nor does it mean your heart is abnormal. We're going to try and get our tricuspid velocity again. All right, we have some information. Okay, one thing we're just stop there. Let's see what we're seeing. I thought I saw, this is probably mitral valve opening right here as a very sharp peak. I thought I saw aortic valve closure earlier on, but I'm not seeing that now. Not seeing a great tricuspid, tricuspid opening. But here's probably our tricuspid regurgitant jet. Not perfect, but there we're seeing it. From that, using the Bernoulli equation, we should calculate the pressure gradient. Let's say it's 22. This is actually probably not correct, but let's just say that it's 22, and let's say their right atrial pressure was 5. Then we can add those two together because, again, what we're estimating is the pressure gradient that allows the ventricle during systole to have a small squirt of blood come back into the atria. For that blood to come back into the atria, the pressure has to exceed the resting pressure in the right atria. And so let's say it's 5. We have to add 5 to, in this case, the 9.86 that we're measuring. And we'd say that the peak systolic pressure in the right ventricle is quite low. It's about 14 to 15, well within the normal range, not elevated. In a patient that had elevated pressures, this would be very useful because we can then determine that. Why don't we see if we can get aortic outflow, aortic ejection. Okay, to give everyone a fair chance, why doesn't Alex, Jordan, and Riley get together in the back of the room and have a rock, paper, scissors for who's coming out? All right, you guys can shoot it out. Okay, so here we're measuring flow moving away from the transducer. Why don't you just stop it, Kelly? Perfect. We see flow out the aortic valve into the aorta itself. You have to do it quietly, though. So what we're seeing is that here's our QRS complex. Systole has been initiated. Aortic valve opens, this sharp peak, and then we have ejection out the aortic valve. So again, this tells us about components of the Wiggers diagram that we can measure. Here we can see our flow out the aorta. Here's the beginning of systole. We can measure our ejection time during this interval here from the aortic ejection. All right, Jeff, thanks very much. And who do we have? All right, so we're going to wind up here, and what I'd like to do, Kelly, is let's get a 4-chamber, and we'll trace some volume. So what I'm going to try and show you in the next couple of minutes is, we've seen the pictures we can take, we've seen some of the timing events we can get, we've seen the anatomy we can get, and what I'd like to do now is, based upon that view of the left ventricle we've seen already, we'll see if we can measure ventricular volumes and calculate a stroke volume. We can, as we're recording the ECG, we determine our heart rate, and having the heart rate and having our stroke volume allows us to calculate what? Cardiac output. Okay. Yeah. Well, let's get a 4-chamber view. Great. All right. Again, tricuspid valve, mitral valve, left ventricle, right ventricle. You see how clearly the U-shaped left ventricle compared to the more triangular-shaped right ventricle.